Hi. Let's see here. There we go. And
Okay. No. Well, I'm the only one here, and I thought maybe I got the wrong place. Sandwiches are here, so. Well, not feel close to you. Well, there's meetings. Tell them. Yeah.
Okay, and then I have to plug this into somewhere.
So, it says usually, here.
Was that where it goes?
Yeah, I have it back here.
Okay.
Well, it'll be an intimate talk.
Sorry?
There's an evaluation put on next door, so I just texted them.
Okay. And people aren't up in the Hurlbird, are they?
No. The Hurlbird doesn't exist for us any longer, and while the CST is, this is all being, everything's moved around because of this CST. You been trained?
Well, yes, I have to. You know, I must say that I'm a little bit, I have to do it. They keep sending me reminders because I've been involved quite a bit in the whole process, but I do have to do the actual training. But I just have too many other things to do right now. But I know that they're really pushing me, so I've got to.
Everybody, not just everybody. And we're all feeling the same way as you are. Not enough time, but it's going to be a real challenge for all of us.
Yeah, it's you know.
You know how to make it both? I'm trying to turn to both screens, but...
They'll come and help. They should be here.
Yeah, I don't think we need to worry about that.
You bring the thing on both?
It looks like nobody's going to be here except usually lunch, actually.
Attracts people, yeah.
I'm not sure.
Well, exactly streaming in. Yeah.
It's not sushi day.
Well, I guess it doesn't have to worry about being late.
No.
You know I was here for 15 minutes before.
I didn't know.
But then I got a bunch of stuff I got to do over there to set up, and then I come back.
I have a cardiologist.
Yeah, it's true. I know, that is kind of close, isn't it? Now? We need Dr. Iggy here. So you, okay, let me just set this up here. Conference. On here?
No.
Oh.
It's on my stick.
Okay, yeah, so pop it, yeah. This is actually fairly new, so you might not be used to it. The plug-in now, best to use these ones here.
You want me to close it down, and then how do I do this?
No, just go ahead and...
But it's not here. It's there and over there.
Sorry, so where's that?
Well, it was on the screen. I don't know what happened.
Oh, I don't know what's going on.
Oh my God.
Oh, I see. This is none. That's why. So let's do. That should be here. There we go. Okay, so that solved that. Now to get it on here, I want to go there because that shouldn't be. No, that should be the lectern PC, and that should do it.
Okay. So do you want me to run it somewhere, or is it okay to run it outside?
I
don't have any moving images or anything.
Yeah, I would just hit here, right?
Okay.
Just hit the arrows.
Okay.
So that's all good, and then that's notes. You don't have notes. So that's good because that's set at notes. Yeah, I think that's all okay now. Yeah, no, I agree that looks a bit confusing. And what it was this one here just needed to be set at like PC. That was it. I think it was at none or laptop or something like that.
I wanted in the end, I wanted to take the slideshow down.
Or escape. You can just hit escape.
And then I should do,
yeah, and now you can access all the rest of the computer or whatever, yeah. Yeah, I think escape does the same thing. Okay. All right.
Is it possible to put it onto this screen? Or is that
yeah, I think I the same thing? Like
well,
this?
it's just that it's easier for me standing here to look at
Yeah, I think I can. Lectern PC. I mean, it's a set of notes, right? It should be there too. Yeah, there you go. There you go.
Okay.
The only thing I can't do is make that slide. Okay, great. And do you want the lapel microphone, or are you okay just standing?
No, I'm okay with that. Okay. I don't need to move around.
I'm going to make sure it's up high enough here. Let's see. I'm going to turn that to 80.
And then 80%. My other question is, I think they record these, right?
Yes, that little red dot there.
So when I have a lot of hidden slides, it's not going to record the hidden slides. It's not going to store the hidden.
Only what's up on the screen. We'll see. Yeah, only what's up. Okay.
It's not like it stores the slides.
That's correct. It's a feed directly identical to that.
Because I've got several talks on, and it's hidden. I'm giving another.
It'd be like if you had notes here, and the slides here, it would only record the slides, not the notes.
Okay.
Yep.
Good.
Okay, awesome.
How long?
I think it's about 45 minutes. Lots of changes.
Morning, everybody. Welcome to Can you hear me? Welcome to Grand Rounds. To the distant sites as well, welcome to Grand Rounds. Today's Grand Round is, as you see, what's new in nuclear medicine and cardiology. Dr. Marla Kiess is going to give us her perspective. She's been doing this activity she is an experienced cardiologist in this area. Dr. Kiess.
Well, thank you for not calling me an old cardiologist. Okay, I'm going to run through what's new in nuclear cardiology. I was kind of amused to see that the original title that was sent out was not the one I sent, What is Nuclear Cardiology? I'm assuming that people have some knowledge about nuclear cardiology, and I'm really only talking about things that are new. And I'm excited that there are quite a few new things, because I think nuclear cardiology for a while was kind of static, but I don't think it is anymore. So this is the outline of what I'm going to talk about. I'm going to talk about technetium pyrophosphate imaging. So this is a very old test with an updated use. I'm going to talk a little bit about perfusion imaging and coronary artery disease, but very focused on several issues rather than a comprehensive review. I'm going to talk about detection of infection. I think this is an area where nuclear medicine is underutilized. I'm just going to mention MUGA or gated imaging, and then I'm going to talk a little bit about PET, because PET is definitely on the horizon finally. So I'm going to spend most of the time talking about cardiac amyloidosis and pyrophosphate imaging. This is a very important area that is becoming increasingly important. We actually described using pyrophosphate imaging in the 70s for this condition, but it kind of disappeared, probably because people got mixed up between the different types of amyloid and it wasn't being used appropriately. So amyloidosis is an infiltrative or a restrictive cardiomyopathy, which is caused by an extracellular deposition of abnormal protein fibrils. And the clinical presentation overlaps with other very common cardiovascular diseases, hypertrophic cardiomyopathy, hypertensive heart disease, aortic stenosis. So it produces hypertrophy, and there are lots of patients that we are calling hypertrophy from other conditions who turn out to have amyloidosis. So in terms of the classification of amyloidosis is very important. In particular, we need to be able to differentiate light chain amyloidosis from transthyretin-related or ATTR amyloidosis. And there are two types of the ATTR amyloidosis that we're interested in. There is the wild type, which is commonly seen in older men. And you can see wild-type deposits in more than 25% of individuals over 80 years of age. And then there is the genetic condition, which is autosomal dominant, and this is the one which we are particularly interested in. There are, at this point, more than 100 known mutations that produce a TTR amyloid, and I'm not going to go into detail with that because I don't have time today. So why do we care about this? And we care about it because there is now treatment for different types of amyloidosis and quite effective treatment. So we become interested now in finding amyloid. So in terms of differentiating the hereditary type versus the wild type, the age at onset can be highly variable. It can be a young person or an older person. As I mentioned, it's an autosomal dominant condition, and it is important to know about this in terms of giving guidance to offspring. There are a huge number of different sorts of genetic abnormalities that have been found, and they have predominance in different parts of the world. What's most common in one area is not necessarily common in the other. These are not good diseases to have. The median survival after diagnosis without treatment for the hereditary type is 2.5 years, and for the wild type is 3.5 years. So in terms of why we're particularly interested in the wild type is that we have treatment for this now, and this is very common. In recent studies, 13% of patients with HFpEF with wall thickness greater than 12 millimeters have amyloid, and anywhere from 6 to 16% of patients undergoing aortic valve replacement have amyloid. So this is just sort of a diagram of what I'm going to talk about. It's important, as I mentioned, to recognize the amyloid cardiomyopathy, and the recognition of this has increased dramatically over the last few years. I'm going to talk about the diagnosis, in which pyrophosphate imaging plays a crucial role, and I'm going to mention but not really discuss the various treatments that have become available. So TTR is responsible for the transportation of thyroxine and retinal binding protein in the circulation. It is produced from a protein encoded on chromosome 18, and as I've already mentioned, you can have either a mutant type or the wild type. So what happens is that the amyloid fibrils become unfolded and don't work properly. This results in aggregation in the myocardium, and that results in a restrictive cardiomyopathy. And in the TTR amyloid, it is also commonly associated with peripheral and or autonomic neuropathy. So if you see a patient with peripheral or autonomic neuropathy, that you should be thinking about amyloid as a potential diagnosis. So this is what the heart looks like. It's very, very thick, and you get this photobiorefringence, which I'm not going to discuss in any detail. on appropriate staining. So why we're particularly interested is because there's been an expanding number of therapies for both TTR amyloid and for light chain amyloid. And these are just 3 New England Journal articles over the last year describing very effective treatments. So, and various targets have been looked at. So the TTR is produced in the liver, so there are drugs that block the protein synthesis. There are drugs that stabilize the amyloid so that it doesn't become unfolded. And then there are other drugs that potentially remove the amyloid fibrils from the heart. So what are the features of the TTR amyloid that we see on common testing of nuclear testing, not nuclear testing, but cardiology testing? So people talk about the ECG and how the patient should have low voltages. It's true, but in only less than 50% of the cases. So patients can have an absolutely normal electrocardiogram. They may have a pseudoinfarct pattern with poor R-wave progression. On echocardiography, there is increased LV wall thickness, and it can be biventricular, so there may be increased RV wall thickness as well. There is an increased echogenicity and sort of a granular or sparkling appearance, and there's a very typical pattern with apical sparing, which we can pick up on a longitudinal strain pattern. I'm going to show you an image of that. I mention this because if you're thinking about amyloid, please ask for strain imaging when you're ordering the echocardiogram, because we don't do it routinely, although hopefully we've been asking the techs to do it in patients with hypertrophy, but it helps if people mention that that's what they're looking for. There are some features on cardiac MRI, diffuse subendocardial or transmural late gadolinium enhancement, increased T1, which is usually diffuse, an increased extracellular volume fraction, and an inability to suppress the myocardial signaling with a particular PSIR late gadolinium enhancement protocol. And then there's nuclear imaging, and for this we're using bone avid tracers. The one we use here is pyrophosphate. You could use MDP, which is mainly used in Europe. So we have here 2 patients looking at the echocardiogram. So both of these patients are gene positive for the gene that causes TTR amyloid. This patient is symptomatic and has hypertrophy, and the strain imaging shows what's been described as a cherry on top with abnormal strain except at the apex. And so these numbers in the middle, the red ones, are normal. This is a patient who's a carrier. And I'm not going to go into any real discussion about this, but now that these genes are being described and these are, have an autosomal dominant inheritance, we're finding a lot of carriers. And many of these carriers have a hypertrophy or mild hypertrophy, and we don't really know at this point in time, for example, how often we should be imaging, when we should start being concerned about these patients. But this is a carrier who has normal strain pattern and presumably is not having problems at the moment. So unfortunately, despite seeing these structural changes, echocardiography is insufficient to distinguish between other types of hypertrophic heart disease and from amyloid, and also cannot distinguish the light chain amyloid from the TTR amyloid. The treatment is completely different, and so it is important to be able to make this distinction. So I just show you 4 echocardiograms. All of these patients have hypertrophy of their myocardium, and these are patients. One patient has Fabry's disease, another Danon's disease, one has a hypertrophic cardiomyopathy, and one has amyloidosis. You can't tell from looking at the echocardiogram which ones have the TTR amyloid compared to these other diseases. So, and the same problem with CMR, with the MR. As I mentioned, there are abnormalities on the MR. You'll see a diffuse pattern of late gadolinium enhancement. If you do, you see abnormal extracellular volume imaging. But again, you can say that there's this high suspicion of amyloid, but you can't distinguish the light chain amyloid from the TTR amyloid. So this is nuclear scintigraphy with pyrophosphate scanning. This is a very old technique. We used to use it extensively in patients with acute myocardial infarction to make a diagnosis before we had very accurate markers, and in particular for late presentations of myocardial infarction. But with the advances in diagnosis of acute myocardial infarction, the use of pyrophosphate imaging really disappeared, and it was only in the last couple of years that we've started doing it again, and now we're doing it specifically to pick up amyloid. So we can grade this visually by comparing the uptake of the tracer to the bones. It's a bone imaging agent. And in the patients who have TTR, they have much hotter uptake in the myocardium than they do in the bone. And so we can grade them whether there's no uptake, mild uptake, moderate, or severe uptake. And if we do SPECT imaging, which is particularly helpful in showing that we're not looking just at blood pool, which is a potential problem, we can see nicely that there's uptake in the myocardium, but not in the blood pool in the center. And then we can quantify this, we call it semi-quantification, by putting a region of interest over the lungs on the right side and comparing that to a region of interest on the heart on the left side. And what's called the heart-lung ratio separates very well amyloid caused by the light chain from the TTR amyloid. It doesn't distinguish between the hereditary and wild-type TTR. I'll talk a little bit about that. This is highly sensitive and specific. You can also do whole body imaging, which may be somewhat helpful in looking at amyloid deposition elsewhere. So this is the kind of report that you're likely to get, and these are the recommendations from multiple societies that have come up with a consensus document on how to report these images. So they will be either not suggestive of TTR cardiac amyloid, strongly suggestive, or equivocal. And most of the ones that are called equivocal are because there is some mild uptake and it's likely to be in the blood pool. So in the context of a patient that has an echo or CMR, strongly suggestive amyloid, and then if the scan is negative, you have to still evaluate the patient for light chain amyloid, because most patients with light chain amyloid do not have uptake, although some may be considered. And I'm going to talk a little more about how we can, I think, now avoid endomyocardial biopsy in most of these patients. So this is a study looking at 1,217 patients with suspected cardiac amyloid, and many of them had endomyocardial biopsies. Most of them had histologically proven amyloid. In this study, bone scintigraphy was 99% sensitive and 86% specific for cardiac TTR amyloid, and the false positives were almost exclusively from uptake in patients with AL amyloid. So if you combine grade 2 or 3 uptake and absence of monoclonal and proteins on blood and urine testing, there's a specificity of specificity and positive predictive value for TTR amyloid of 100%. This is a very, very good test. It's also a very cheap test and a very easy test to do. So in terms of do we still need to do endomyocardial biopsies, this is the study that I just mentioned, which again showing a very high sensitivity with negative markers in the blood and grade 2 and 3 uptake of pyrophosphate. And when they looked at, if you had a scan grade of 0, which was 49% of the patients, there were only 2 with TTR amyloid. When you looked at scan grade 1 or a mild abnormality, there were some patients with TTR amyloid. And then if you looked at scan 2 and 3, there were virtually all of these patients had TTR amyloid. So in conclusion, if you have a patient who has heart failure, an echo or CMR that's consistent with or suggestive of amyloidosis, grade 2 or 3 cardiac uptake on a radionuclide scan. Here we're using pyrophosphate, but you could use other bone imaging agents. And you do not have any detectable monoclonal protein in the serum or urine, then the consensus opinion at this point in time is you don't need to go ahead with biopsy, that you can go ahead and treat the patient. I think I forgot to put into this talk that there is a special clinic for cardiac amyloid at VGH. If you have a patient that you that has amyloid after testing, I would strongly recommend that you refer the patient to that clinic. So this is looking at survival in patients with TTR amyloid. So those who had a ratio of greater than 1.6 had a much worse survival than patients with a ratio that less than 1.6. So I don't think I'm going to talk about that. Basically, I've already mentioned this. So this is now the diagnostic algorithm that's being put forth by multiple societies for investigation of patients. So if you have a patient that you think may have amyloid, so they would have heart failure, syncope, bradyarrhythmias, with an echo and or cardiac MR suggesting amyloid, that you go ahead simultaneously, probably would be best, with looking at serum markers to rule out AL amyloid and bone scintigraphy to make a diagnosis of TTR amyloid. So if you have no markers for light chain amyloid, then let me just say, so yeah, so if you have the bone scintigraphy is negative and the markers are negative, you'll know that cardiac amyloid is highly unlikely. If the markers are positive, then that would suggest AL amyloid, and you go down into a stream for typing that and treating the patient. If you have the grade 2 or 3 uptake on the bone scan, then again, if you don't have any AL markers in the blood or urine, then you need to do TTR genotyping to find out whether this is the wild type amyloid or whether it's the hereditary type amyloid for appropriate treatment of the patient. So I'm not going to, this is basically the same thing. I should mention that some of the things that are commonly associated with TTR amyloid, carpal tunnel syndrome. So if you just look at patients who present with carpal tunnel syndrome, those patients have a much worse prognosis than patients who are control patients. If you see an older person, elderly person in particular, needing to have carpal tunnel surgery, amyloid is most likely what the problem is, and you should be investigating that patient for amyloid. Aortic valve replacement. So there are several studies now showing that many of the patients presenting, who of course have hypertrophy related to their aortic valve, but in particular patients presenting with low flow, low gradient aortic stenosis, that many of these patients have TTR amyloid, in this particular study in men up to 22%. That may, we don't know whether, and there are studies going on at the moment to determine whether those patients should still have aortic valve replacement or whether they should just be treated for T Tr Amyloid. I suspect they may still need the aortic valve replacement, but certainly this is an area where there's research going on at the moment, but definitely you should be thinking about it. The other big group of patients is patients in the hypertrophic cardiomyopathy clinic, of which a significant number. So when should you think of these patients? You've got patients with HFpEF, unexplained hypertrophy, African Americans greater than 60 with heart failure, age greater than 60 with unexplained HFpEF, individuals with heart failure and unexplained neuropathy, bilateral carpal tunnel syndrome, atrial arrhythmias. In particular, elderly patients have been treated for years for hypertension and now are getting into problems with hypotension. And frequently that's because of the amyloid and autonomic neuropathy, known or suspected familial amyloid, and then of course those who've had testing suggested. And I'm going to now sort of shift gears entirely and talk about some changes in myocardial perfusion imaging with SPECT. So this is a totally different topic. We're very keen in imaging on indicators of quality, and we have, I would say this has been a huge growth in imaging in terms of making sure that we're safe with our imaging, we're effective, that we're patient-centered, timely, and efficient. And there are a number of processes, and some of which I'm going to discuss, that are important in this. We have really shifted a lot to the concept of patient-centered imaging, and so we want to make sure that we do the appropriate tests for the patient. We want to make sure that the protocols are standardized so that we're going to make sure that the results are accurate, and this is going to give us imaging-guided care. So this requires a discussion between the patient, the physician ordering the test, and the imaging physician. So over the last few years, we have changed our concept of coronary artery disease. In the 80s and even until very recently, we were very focused on lesions. So do we have coronary artery stenosis, and do we need to treat that? We got a little more sophisticated in understanding about vulnerable plaques, which can erupt and cause myocardial infarction. These plaques do not have to be flow limiting, so that was a totally new concept. We focused very much on ischemia in terms of treatment and detection, and now we're realizing that a lot of what is causing coronary disease is inflammation, which is a key factor both in activity and risk. So we're shifting a lot of our focus away from so much ischemia-driven is to treating inflammation and trying to understand which patient is vulnerable and which patient is not. So this has moved us into wanting to know whether the patient actually has atherosclerosis as opposed to just wanting to know if the patient has ischemia. And so that we become very aggressive in treating atherosclerosis because we know that the risk of myocardial infarction and cardiovascular death goes up with the atherosclerotic burden. So clinical, but also subclinical atherosclerotic burden is a major focus of our interest now, and because it's a major determinant of adverse outcome. So we are becoming much more interested in early detection and prevention as opposed to just revascularizing lesions. And we know that in 50% of patients who present with symptomatic atherosclerosis, the first symptom is myocardial infarction or sudden death. This has not changed over many, many, many years. Now, the number of patients presenting has decreased, changes in mainly lifestyle modification and improvements in treatment like statins, But the reality is that still 50% of patients have their first symptom as cardiac death or acute myocardial infarction. So we are trying to shift our emphasis into finding these patients before they present. So there are many things that you want to do when you are evaluating a patient, and obviously you're going to look at the patient's risk factors. Exercise capacity is an important, if you have to have a pharmacologic stress test, that's a negative risk factor. If you have poor musculoskeletal function, particularly upper arm function, that's a very bad risk factor. Autonomic function, if you have poor heart rate recovery, that is a sign of autonomic dysfunction, and that increases the risk of death. Of course, the atherosclerotic burden, which I'm going to talk about so much. And symptoms are extremely important. Psychosocial status is also extremely important. There's more and more being written about this. Are we going underwater? Sounds like it. Okay. And just looking at your mortality risk according to your risk factor burden and whether or not you can exercise, if you can walk on a treadmill and you don't have any risk factors, you do extremely well. And this is a study of almost 6,000 patients with a normal perfusion scan followed for 8 years. However, even with a normal perfusion scan, if you can't walk on a treadmill and need to have a pharmacological stress test to have your perfusion scan, and you have more than 2 risk factors, your survival is very poor, 50% over 15 years. So exercise capacity is important. Numbers of risk factors are important. And these numbers are adjusted for age, gender, ethnicity, hyperlipidemia, family history, etc. And chest pain symptoms. So this has just been came out at ESC a couple of weeks ago, which is the European Society of Cardiology's new approach to what they're calling chronic coronary artery disease. And the AHA, ACC are coming out with a similar document, which is going to be announced in November. And I think we're going to be seeing a major shift in emphasis. So obviously, you want to assess the patient, and if the patient has unstable angina, they go off into a separate set of guidelines. Major emphasis on patient-centered care. So consider the patient. If the patient is not going to benefit from revascularization and you don't, or doesn't want revascularization, you probably will be opting not to do a bunch of tests to understand how much coronary disease they have and would give them medical therapy to treat their symptoms. If the patient has left ventricular dysfunction, you go down a separate pathway. So we're talking about, when we're talking about doing imaging tests, we're talking about evaluating a pretest likelihood, and I'll talk about that. Ruling out patients who have chest pain for obvious causes other than coronary disease and treating them. And then we're left with a group of patients that we're going to offer diagnostic testing to. So if we have a very low likelihood of coronary disease, then the patient will benefit from coronary artery calcium scanning, which unfortunately we don't have available to us as a single test because there's no fee for it in the fee schedule, or coronary CT angiography. And I think Jonathan talked at these, or Leipzig talked at these rounds a few months ago and talked extensively about the use of CTA. When you have moderate to high risk of coronary artery disease, then still an ischemia test, plus or minus other tests, is preferred. And if you have a very high risk, in order a patient has very frequent symptoms or has very clear classic symptoms, you might choose to go to invasive angiography. However, the emphasis is really on doing some sort of non-invasive testing to define, one, does the patient have atherosclerosis, And 2, is there evidence of ischemia before moving on to invasive angiography. So when you look at this is also from that ESC document on the determinants of the clinical likelihood of obstructive coronary disease. You can look at a probability based on sex, age, and the nature of the symptoms. Traditionally, we've used the Diamond and Forrester classification for that. That's a very old one, which we know over-diagnosis or the pretest probability is too high from that categorization. ESC has come up with a new table. I didn't put it in here, but you can look this up. It's freely available to everybody who goes to the ESC website. You don't need to be a member. So if you have a no calcium score, and I'll talk a little bit more about that, the likelihood of coronary disease is extremely low. If you have a normal exercise ECG and no calcium, that's extremely reassuring, and in a very low likelihood patient, probably the most effective and cheapest thing to do would be a calcium score and a stress test. Things that increase the likelihood are risk factors, of course, the traditional risk factors, resting ST segment changes, left ventricular dysfunction, abnormal stress test, and coronary calcium on a CT scan. So the shift has been to looking for atherosclerosis. So you can do that with coronary calcium scanning, or you could do it with a CTA. So you would like to preferentially consider that if there's a low clinical likelihood. The patient characteristics are such that you think you're going to get a decent image, and you've got local expertise and availability, which we have. We have expertise. The availability is improving. And you really want to know whether the patient has atherosclerosis, not so much about whether they're having ischemia. And then you would appropriately treat the patient with drugs, and only if they have ongoing symptoms, then go ahead to invasive coronary angiography. If the patient has symptoms and the CTA comes out with multiple lesions of 30 to 70% or intermediate probability disease, you would most likely want to go ahead with a functional test, and that functional test could be many different things, which I'll talk about. And then only if you have significant areas of ischemia and you think the patient needs revascularization would you go on to invasive coronary angiography. So there are a number of different ways of diagnosing ischemia, and there's the stress ECG, and this is the red bars are the range where you can rule in coronary disease with the test, and the green bars are where it's good to rule out coronary disease with the test. So as you can see, the exercise ECG is not very good it's good in a very low likelihood patient for ruling out disease, and it's good in a high likelihood patient for ruling in disease, but there's a huge gap in the middle. Coronary CTA is very good in low likelihood disease. If there's previous coronary disease or high likelihood disease, certainly it will find disease but not be helpful with ischemia. I'm going to talk about PET imaging, and then you can use PET imaging with stress, MR with stress, which we're not doing here, stress echo with perfusion imaging, which we haven't yet been doing here but may in the future, and myocardial perfusion imaging. All of these tests will be able to tell you whether the patient has coronary artery disease. So what's the difference between an anatomic test and a functional test? So an anatomic test is a test which tells you, does the patient actually have coronary disease? So on a very simple level, calcium scoring will tell you whether the patient has atherosclerosis, and coronary CT coronary angiography will give you additional information over where that disease might be and the burden of atherosclerosis. And invasive coronary angiography, of course, will do that as well, but we really don't want to go to invasive tests unless we think that we need to have reperfusion. So functional testing is different. Functional testing is focused on, does the patient actually have ischemia as a result of their atherosclerosis? Are the patient's symptoms due to the coronary disease? What's the significance of a lesion on anatomic testing? And it's particularly good at looking at patient prognosis. So what kind of things are functional tests? Well, stress testing is a simple test, and we already talked about how if patients can't exercise, they have a poor prognosis. You have perfusion imaging, which can be done in this center at the moment, mainly is pretty well done by nuclear imaging, but there are other techniques that could be used. Plaque characterization, I think, is very promising with CT coronary angiogram. There is I don't know if Jonathan talked about FFR, but that's coming in the future and may be helpful. So when we look at the ischemic cascade, you have subclinical coronary disease, which a calcium score or CT coronary angiogram will pick up. And as you get, as it starts to affect the vessels, then you'll get progressive endothelial and microvascular dysfunction. For this, the best measurement is coronary flow reserve. And I'm going to talk about that because I think it's a major thing in that we can now measure coronary flow reserve very well with PET imaging. Then you get coronary flow maldistribution, myocardial hypoperfusion, which is what we pick up with the nuclear myocardial perfusion imaging, and then you get diastolic dysfunction, you get systolic dysfunction when stress echo is helpful, and when things are really getting to be more serious, the stress test is going to produce ECG changes. So I'm going to just talk briefly about calcium scoring. It's unfortunate that it's not available to us as a single test, although we do it in combination with myocardial perfusion imaging, and is extremely valuable in that regard, and you can request that. So if you look at patients that have a positive calcium score, if you look at patients who have myocardial infarction or unstable angina, almost all of them will have a positive calcium score, and you can divide that into young patients and old patients. If you look at the calcium score, and then you looked at the patients with an abnormal perfusion imaging, the colors are different studies that have been done by different centers. So mostly if you have a low calcium score less than 100, you usually have a normal perfusion scan, and there's usually a good correlation between that. As you get a higher calcium score, you start to have more likelihood that you'll have an abnormal SPECT scan. And then, of course, if you have a high calcium score, you'll get a much higher number of patients with an abnormal SPECT scan, but still only 35%. So you can have quite a bit of calcium in your coronary arteries, but not have flow-limiting disease producing ischemia. So it does give you different information. So, and if you just look at the calcium score, and by itself, it's very helpful in defining what the patient's risk is going to be. So if you have a low calcium score, then you have a high, then your prognosis is very good but if you have a higher calcium score and as time goes on, then your prognosis is bad. If you look at the presence or absence of a lesion on CTA, then of course you're, over time, you're more likely to have a decreased survival. But if you have a 0 calcium score, even if you have a lesion on coronary CTA, you have an excellent prognosis. So when you look at cardiac events, again, with a low calcium score, the number of events is very low. and then as your calcium score goes up, then the event rate increases, and as the calcium score goes up, it does help to know whether the patient has ischemia, because if you have an abnormal SPECT scan, then you will have an increased event rate. And these are total events or death and myocardial infarction, which are very hard events rather than just looking at revascularization. So the calcium score provides both independent and complementary prediction with the perfusion imaging and is helpful when done together. So what are the benefits? It gives you superior risk stratification, better at defining whether the patient truly has atherosclerosis or not. It can act as a gatekeeper to functional testing. It's cost effective. This is a U.S. slide. We don't have it available in British Columbia, although available in other provinces in terms of just ordering it. However, there aren't a lot of randomized controlled trials. But I think in the future there's a lot of interest in just looking at the calcium score. I'm going to talk, because I'm talking about nuclear cardiology, I'm going to talk a bit about radiation exposure and how that might influence. So one of the things that we're doing now is focusing a lot of our effort on making sure that the patient gets the best test with the lowest radiation dose. So when you look at your annual background exposure, living in Vancouver, you're going to get about 3 millisieverts of radiation per year. If you live at Whistler, or if you live in the Kootenays, it's going to be much higher than that. So the closer you are to the sun, the more flights you take, the higher radiation exposure that you have during the course of a year. I just want to mention that to keep in perspective what we're talking about here. Invasive coronary angiography, this is an average, 7 millisieverts. Rest stress perfusion imaging, if you do both injections, about 11 millisieverts. Stress-only perfusion imaging, about 3 millisieverts. If you do PET rest stress imaging, about 3 millisieverts. And if you, depending on the isotope you use, you can get that down even to 2 millisieverts. Stress-only would be less than 1 millisievert, which is one of the reasons why we're very interested in getting PET. If you do a CT coronary angiogram, in many areas of this province, you're going to get about 10 millisieverts. In this hospital, you're going to be down probably around 2 millisieverts. So it really depends on the technique that you use. And if you just do calcium scoring, you're going to be around 1 to 2 millisieverts. So just to give you an idea of the relationship or the different doses. So what about, people are always worried about the lifetime risk of cancer with radiation. I think that's very appropriate. And this is a slide that's looking at different protocols, but it's also looking at males and females, so that's very helpful. And it looks at age. So age is extremely important. If you're 70 years old and you have a myocardial perfusion scan, you have multiple CT scans, you have multiple radiation, the chance of developing cancer from that is virtually zero. So we're not particularly worried about older patients. We are definitely worried about young patients. And I think we have to have good reasons for doing imaging in patients in their 30s and 40s and certainly in children. So I would keep that very much in mind. We do get a significant number of requests for perfusion imaging in 30 and 40-year-old patients, and many times those are totally inappropriate. So I would discourage you from doing that unless you really think that there's a good reason for it. And there may be, but you should think about it. So the other thing we're doing is trying to, of course, reduce the radiation dose and therefore reduce the risk. The lowest risk is with, of course, the lowest testing, which is going to be PET scanning. the perfusion imaging with technetium, which is what we do now, is intermediate, and the highest risk is thallium, which we don't use anymore in this institution anyways. So I would ask you to think about patient's age when you are thinking about an imaging test, and that would apply to any imaging test in which there's radiation. We are very focused, as I said, on reducing radiation dose, and one of the things that we can do is stress-only imaging. So in patients that we think have a low risk of disease, we can just do the stress part of the study and only do the rest part of the study if the stress is abnormal. And this is a big study that has looked at doing stress only versus stress and rest, and looking at percent survival. And you can see that there's no significant difference in all patients, whether we have coronary disease or do not have coronary artery disease. So I think that stress-only imaging can be done safely, and we try to do that as much as possible. There is a benefit to adding stress-only imaging and calcium scoring, which we can do and will do if people request it, and that really adds to our certainty that the image is completely normal. We're very reassured, even if there may be some artifacts, which we may have from example patients with large breasts or larger sized patients. If the calcium score is completely normal, then we feel confident to say that we're okay with the stress-only imaging and don't need to go ahead. This reduces the radiation exposure significantly and can reduce it down to the level of CT coronary angiography. I already talked about exercise, and I'm not going to talk about, and just remind people that prognosis is one of the most important things that we do in nuclear cardiology, and that the number of events is related to the size of the perfusion defect, and also to your to your ejection fraction. I'm going to move ahead because I'm running out of time here. So I just want to mention that there's a tremendous underuse of nuclear imaging for infection. White cell scanning is very, very helpful for patients, particularly patients with devices like mechanical valves, patients with, and patients who have devices such as LVADs. This is particularly good with PET, but can be done with SPECT. This is just an example of an LVAD patient with uptake along the drive line. And you can see here that the specificity for, this is leukocyte scintigraphy, indium-labeled white cells, is 100%. So it's a very, very good test. If you want a very sensitive test, you would do PET, which we don't have at the moment. And patients with endocarditis, if you look at the PET imaging, it can be very helpful in defining what their prognosis was going to be. I'm going to move to PET because we are definitely running out of time here. So the exciting thing about PET is the ability to, in coronary disease, is the ability to be able to measure myocardial blood flow and coronary flow reserve. So this allows us to look at the whole tree of the coronary arteries. So we get atherosclerosis in the large vessels, we can look at vasospastic disease, and then we can look at the small vessels. And this is particularly important in women and other patients who have microvascular dysfunction. So this is really an improvement and something I really wish that we had. I'm not going to go into this, but there is no correlation or minimal correlation between coronary flow reserve and the extent and severity of angiographic disease, which is one of the reasons why just looking at an angiogram is not necessarily the best way of treating the patient. It's particularly important in women. Women have a high amount of impaired coronary flow reserve and non-obstructive coronary disease. So this is a significant issue for women, less of an issue for men. And we know that when you have abnormal coronary flow reserve, that your mortality goes up. I don't have time to go through all of these slides, but the yellow people here are the patients who have abnormal coronary reserve and do not have large vessel coronary disease. And these patients, as you can see from the red dots, do die. So it is important to be able to pick up these patients, and we don't have very effective ways of doing that currently. The most effective way is to do PET scanning. You can do it with drugs in the cath lab, but that's not being done currently. So there are also a whole host of inflammatory diseases I'd like to remind you of that are associated with a higher risk of coronary disease that can be picked up, and PET is particularly good with this, and very sensitive and specific in these patients. So SLE, psoriasis, rheumatoid arthritis, ankylosing spondylitis, chronic kidney disease, inflammatory bowel disease, diabetes, metabolic syndrome, and so on. So all of these patients, HIV patients particularly, and certain drugs, have an increased risk of coronary disease, and I would say that we are under-testing these groups of patients. Sarcoid. So I'm just going to mention that PET imaging is the drug of choice for looking for sarcoid in the heart. We currently have some time for something like 20 patients a year at the PET scanner at the Cancer Agency for this purpose, but there are a lot more patients that would be served by having this, and so we are keen to be able to get a PET scan. So what are the advantages of having a PET scan? First of all, there's much better sensitivity in detecting ischemia with lower radiation dose, and I didn't talk about throughput, but you can do many more patients on your scanner. You can measure real coronary blood flow and coronary flow reserve, and this is extremely helpful when you know that the patient has disease, you know there are lesions, but you don't know whether those lesions are going to be significant or not. I didn't talk about viability, but it's very good for that. It's good for detection of infection and inflammation. It's also interestingly good for picking up optimal sites for VT ablation. And I'm not talking about molecular imaging. There are a number of tracers that can look at different things now, different molecular pathways that are being in phase 2 and phase 3 trials for patients and will be coming in the future. So there are many other advances in nuclear cardiology, the imaging that I haven't discussed. There are improvements in camera design, imaging protocols, the rapidity of our computers, which allows us to do many things. Machine learning is a very big thing in terms of standardization of imaging, standardized reporting protocols, phase analysis, an old technique, but being brought forward to look at desynchrony and predicting response to CRT, neuroreceptor imaging for predicting patients benefit from an ICD. This is still in, I think, trials, and I mentioned molecular imaging. So in summary, I spent a lot of time talking about pyrophosphate imaging, which is highly sensitive and specific for diagnosing T Tr Amyloid. Perfusion imaging with SPECT remains helpful determining the significant coronary disease and patient prognosis, and will do so despite the advent of CT coronary angiography. Calcium scoring with stress-only perfusion imaging can be very helpful both in determining atherosclerosis and ischemia with a low radiation dose. I wanted to emphasize white cell imaging, which is very helpful and not very much used in our institution. And of course, we're very excited about the advent of PET imaging, which allows new and unique opportunities for evaluating cardiovascular disease and improving our ability to evaluate myocardial perfusion with a lower radiation dose. And we have money for a PET. We have approval by the government for a PET. We just need to convince the hospital to spend some money renovating before we move to the new hospital, which is a bit of a stumbling block at the present time, since they don't seem to be keen about spending money on renovation in this building. So thank you very much.
Thanks, Marla. I think it's past one. I don't think we have any time for questions, but if you would like to, if you have questions, maybe Dr. Kiess will stay around for a few minutes. Thank you very much.
Thank you.
Marla, quick question for you.
Yeah.
For, let's say, patients, as you were mentioning, with like unexplained peripheral neuropathies, who, let's say, don't have any cardiac symptoms, does it still work well doing a cardiac echo?
Yeah, it is worthwhile. Yeah.
So I'm thinking of specific patients in mind.
Well, you know, and I must say, I've really been learning about this myself for the last couple of years. It's just become a very hot topic of reading. And I can think of a number of patients, you know, that I couldn't figure out what's going on.
It's just a shame to wait until they have congestive heart failure.
Right. You know, there are a number who have turned up to me with peripheral neuropathy as a major complaint. But they have heart problems. They usually have hypertension, for which they've been treated, and how LDH, and they have peripheral neuropathy, they don't have heart.
Right.
And it's their biggest complaint.
Yeah.
And it hasn't occurred to me to think about amyloid.
I've got a guy who's like early 50s. He's having like for the last 5 years symptoms of progressive peripheral neuropathy, seen by neurology, and no specific diagnosis. He doesn't have diabetes, doesn't have, like he's not a drinker, you know, so none of the classic risk factors.
Well, actually, I was just at the American Society of Nuclear Cardiology meeting last week, and there was a guy there who gave an absolutely superb talk about how, you know, it can take up to 5 years for a patient to get a diagnosis of amyloid, light chain amyloid, and that, you know, multiple complaints, seeing neurologists, you know, they're going to a surgeon having cardiac macroglossia. There are a whole bunch of other things where people have seen commonly up to 5 specialists before anybody has thought to think about amyloid.
And when we get like a echo report that shows like hypertrophy, will it, if it's suggested of amyloid, will they actually comment on that, or will they not?
I think that not necessarily. Right. I personally have started doing that. I didn't used to. So, you know, if it's very thick, if it has that kind of sparkly appearance, I would say think about amyloid. I know Rob Moss does that too. I don't think it's done
not necessarily
routinely. It's certainly something we've been thinking, I think, should be discussed, particularly with availability of pyrophosphate imaging now.
Because we see so many patients with hypertension who have hypertrophy, and the question is always, hypertension is common, but you know, the numbers suggest that amyloid is actually fairly common as well, right? So you're going to have people that have both. And so how do you differentiate those who have just hypertension versus hypertension for amyloid on the echoes? Right.
So that's where, you know, and the echo is as I said, non-statistical.
Right.
It's just the hypertrophy. Right. The strain imaging is but you know, not all patients will have that, but a large number do. So we're increasingly doing.
So I'm definitely going to get an echo of my guy and ask for strain imaging. That'd be interesting just to see. Just because he's a young, healthy guy, but he's having progressive symptoms.
And so now you're seeing all this genetic testing, and you're picking up carriers, you know, and some of them have positive pyrophosphate scans. I said, you know, there were good examples showing that, but they're totally asymptomatic. They don't have severe LDH, and what do you do? You know, do you treat those patients? Well, I don't think you do at this moment. They won't. I don't think it's sort of. And then, like, if the first echo is unremarkable, do another one in 5 years? Or? Well, exactly. Well, that's the thing. You know, the question. That's the question. How often do you test patients? If you get a negative pyrophosphate scan, does that mean something? We don't have any knowledge about carriers yet. Right. You know, I mean, should they have a scan or shouldn't they have a scan? Should they just have an echo? Should they? You know, but I think we are going to get to the point, because by the time you get to treatment phase, these drugs are expensive. Then, you know, they're not. They are improving life expectancy, but I don't think they're putting it down to normal. Right. So certainly they'd be more effective
in hopefully preventing deterioration rather than once they've already got it.
Exactly. So, it's opened up a whole new field. I mean, this is really a very active field of research.
Yeah, so this is great for me because of this one specific patient that I have in mind. Yeah. Okay, I'm going to do that then.
Yeah. I'm thinking my cleaning lady, she's 80 years old. She's worked for me for over 20 years. She just had bilateral cardiopulmonary surgery, and she has hypertension.
Yeah.
And I'm thinking, and she's short of breath. And she's not heart failure, but I mean, her exercise capacity is not what it should be.
Yeah.
And I'm thinking, oh.
It's one of these things where when we look for it more, we're going to find it.
Exactly.
Yeah. Thank you very much. Hello, excuse me.
Hello?
Hi. Can you discontinue this session from your end? We're in Eaglewood Hospital and we don't, well, the round is done and we can't actually discontinue from our end. And whatever you're doing over there is being broadcasted over here.
Okay, I am not sure how to disconnect it because I'm just
Is there like a big red button, power button that you can push and like kill everything?
Oh, that's for YouTube.
Thank you.
Okay.
Your call will be disconnected.